Bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, the McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and the Children's Hospital Foundation of Manitoba. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities. All right, hello everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Pediatric Health Centres. So today's webinar is titled Social Paediatrics as Defined by the Health and Well-Being of Children and Youth at Risk, the Disadvantaged, the Dispossessed, and the Discarded. And once again, we are very excited to welcome back our colleagues from PCC, which is the Pediatric Chairs of Canada. You may recall about a year ago we introduced our CAPHC audience to sort of introduced them to Social Paediatrics, either at that webinar series we had about a year ago. We also had a session at our annual conference that focused on Social Paediatrics, and we talked about just really the introduction to the concepts in school-based programs, vulnerable populations, and all sorts of other interesting topics. And at this two-part series that we start this week and continues again next week, we're just going to continue on with that conversation. So it's my pleasure to welcome back Dr. Denis Daneman, who was my co-host at that last session that we did a year ago, that last series. And Dr. Daneman is the Professor of Pediatrics and Chair of the Department of Pediatrics at the University of Toronto Faculty of Medicine and Pediatrician-in-Chief at the Hospital for Sick Children. And he's also the Past-Chair of the Pediatric Chairs of Canada. So it's my pleasure to hand the virtual podium over to Dr. Denis Daneman as my co-host. Over to you.
Thanks a million, Doug. Let me say at the outset that I'm thrilled that CAPHC and particularly Doug Maynard have been incredibly helpful in setting this up for us. The first series of the series that we presented last year were very successful, and we hope that this two-part series will add to that and provide some new insights as well. Today is start off with me giving a small introduction, then Susanna Talarico from Sick Kids and the University of Toronto talking about the impact of undergrad medical education experiences to the attitudes of medical students. Tony Barazino from St. Michael's Hospital in the University of Toronto will talk to how are the children of refugees and immigrants doing in Canada. Andrea Hunter from McMaster will talk about what should pediatricians be thinking and doing about advocacy for child health. Leanne Chapman of the Pro Bono Law Office in Toronto will be talking about legal challenges for refugee and immigrant families. And we hope that Ayal Cohen will join us towards the end from Sick Kids and U of T to talk to the socioeconomic impact of a child who is medically fragile. So after I'm finished, these will just flow one after the other. Next week we will have Jim Kellner introducing Lisa Robinson, Lindy Sampson, Sloan Freeman, Roxanne Goldade, talking to another set of issues to do with social pediatrics. So by way of introduction, let me say a few things. Social pediatrics to me refers to the health and well-being of children, most specifically those living at the margins of society, the dispossessed, the disadvantaged, or the disabled. And this description hinges very much on recognizing the social determinants of health as critical mediators of the health and well-being of children. I've put at the bottom of this slide the fact that I think the use of the term social pediatrics is somewhat unfortunate because it makes this area the exclusive domain of pediatric healthcare professionals rather than society at large. And I think we should think in the future of calling this child health and well-being. That said, for the purpose of this webinar, at least we're talking about social pediatrics. So the purpose of the webinar series is to move pediatrics and child health onto the agenda at the federal and provincial level. When we did a workshop at CAPHC, not last year but the year before, Jeffrey Simpson from the Globe and Mail said very clearly that child health and well-being is not on the agenda at either the federal or provincial health levels, and we have to do what we can to try and get it there. To maintain the strong light on the plight of the disadvantaged children and youth in our society and extend the scope of our first webinar series. So this tells you my view of how pediatrics and child health occurs. On the right, you see a vertical red line, which is tertiary quaternary care, which occurs at major children's hospitals in the province of Ontario and across the country. And as we go from the tertiary quaternary care to secondary care to primary care to public health, we see the role of the social determinants of health playing an ever-increasing role. Not that they're not important throughout, but they play a much more important role as we go through. That lightning bolt shows the schism between what I've termed primary care and individual rights to the right of the lightning bolt, and public health and the common good to the left of it. And we see this very much in issues to do at the moment with poor vaccination uptake that we see in Canada. So where is Canada according to the UNICEF guidelines? We're stuck in the middle. My terminology for it is splat in the middle. The UNICEF scorecard IRC 11, which came out about 3 years ago, suggested that Canada was number 17 of the 29 wealthiest countries in the world. Not a very wonderful place to be. We ranked number 16 in behaviors and risk. We ranked number 15 in material well-being. We ranked number 14 in education. We ranked very poorly in many other things as well. Some of the assessments were somewhat inaccurate, but overall we were not doing anywhere near as well as we should be doing. What's happened since then? Well, between IRC 11 and IRC 12, a further 2.6 million in the rich world children moved into the area of poverty. But what happened in Canada is quite interesting. This slide shows the IRC 11 data, which showed that in terms of material well-being, Canada was splat in the middle, and when it came to childhood poverty rates, we were sitting in the lowest tertile, a place that we really don't want to be and should be, if anything, quite ashamed of. Fortunately, in IRC 12, Canada has moved up somewhat in that there has been a decrease in child poverty in Canada by 2.44%, and this puts us in the better half of the situation. Better, but nowhere near good enough. So what are the solutions? Well, it seems that where there's no will, there's no way, and we need to find some ways that there is will and there are ways. Gary Block suggested a solution. He's a family practitioner at St. Michael's Hospital in Toronto, that we needed to give dollars to needy mothers to improve child health outcomes. This seems crazy, but I think when you think about it very carefully, it's not nearly as crazy as it seems. And then there's the issue of job creation, job training, better minimum wage, and better child care facilities. This sounds like the New Deal of Franklin D. Roosevelt, but it's time that we thought about that in a way that affected the child poverty in Canada. And I think what we're focusing on in this webinar series are the big five: food security, and I put in brackets school meals as one of those, shelter and affordable housing, clean water and immunizations, access to education, and freedom from violence. So I've put here, it seems as if I should actually call it trickle-down economics, but it is so foolish that I've called it trickle-down economics because it was never been proved to have an effect. This is cutting taxes and allowing the rich to pay less taxes so that they make more jobs for the poor. What's happening when you do that, the rich get richer and the poor get poorer. So we need to have a way in which we decrease income inequality, which to me is standing squarely in the way of equity and many different issues in Canadian society. Unlike poverty in many of the poorer countries in the world, such as Africa, for example, Canadian poverty is very neatly hidden. Refugees and many immigrants have a fear of exposure. We hide the issues of Aboriginal health on the reservations, and we need to bring this to the fore so something can be done about it. So I'm going to stop here and ask Susanna Talarico to kick off with her presentation.
Thank you, Denis. Okay, so good morning, everyone. I'm very excited to be speaking this morning as I first became interested in child health and well-being during my first career as a high school math teacher, which motivated me to become a physician and then go on to complete a master's in community health, where I really learned about the social determinants of health, and how to do good advocacy work. So this project that I'm going to present to you this morning, Fostering Transformative Learning in a Social Pediatrics Research Summer Studentship, really brings together my two passions and my two worlds of education and social pediatrics. Okay. And people often ask me when I say I'm doing work in social pediatrics, even though we've known for 200 years, dating back to the work of Virchow, that a child's health is closely linked to their social context, it's only in the last few decades that social pediatrics has really emerged as a field. And I often give this definition that we've heard twice already today by Denis, that it's the health and well-being of those that are disadvantaged, disabled, and dispossessed. And as a teacher, I had really noticed how disadvantaged students that were poor or students that had mental health were within the school system. And so as a healthcare professional and as a medical educator, I'm reminded of my responsibility to teach students about this. So the 2010 FMEC report, or the Future of Medical Education in Canada report, emphasizes this responsibility that we have to address individual and community needs, to support medical students and also faculty in community advocacy work, and to provide students with these opportunities to work in marginalized communities. And so out of this responsibility was created the Social Pediatrics Research Summer Studentship 3 years ago, specifically to provide undergraduate medical students with a research experience in social pediatrics. And there's a huge hidden curriculum to encourage the role of child health advocacy both in the undergraduate medical student population and within our own faculty in Toronto. And so students in their first or their second year of medical school at U of T were eligible to apply to the Social Pediatrics Research Program, which we call the SPRESS program. And each year, 8 to 10 students were selected to participate. Project over 8 weeks, and at the end of the 8 weeks, to present their findings in a scholarly manner. And these projects range from school-based health clinics to developing developmental passports to looking at tuberculosis in Canadian children. And the students received a stipend over the summer to allow them to really dedicate their summer to this project. The students were expected to attend a series of 6 seminars and to complete mandatory assigned readings. The seminars and the readings focused around global health ethics, the role of the physician as advocate, advocacy and the social politics of health, and more practical topics that the students asked for, like how do we go about developing an advocacy project? This theory is great, but I want to do something about it. How do I do it? And each of these seminars was attended by a faculty member. Last year it was myself, the year before that Tina Martimaniakis, to support and encourage discussion among the students. As part of their summer experience, students also participated in clinical experiences that correspond and their research projects. And then we asked them to critically reflect on these experiences, their clinical experiences, in relation to what they were learning through the readings, the seminars, and in their research work. And we asked them both to talk about these experiences in the group and to write a reflection. And for many students, this was the first time that they were asked to write a reflection, and so we provided them with an introduction or an orientation to reflective practice. And during this orientation, I asked them to choose a significant event that's going to happen over the summer or a disorienting dilemma to stimulate reflection. And this idea of a disorienting dilemma comes from the theory of transformative learning. So a theorist named Meserow believes that adults have to reflect in order to learn, that our learning is delineated by cognitive schemas or learning structures, and the only way we're going to learn something new is if we shake up these cognitive schemas when we're confronted by a disorienting dilemma. So this theory fits nicely with our program, so we infused it into the curriculum design and into the program evaluation in order to both facilitate conversation and to assess the program. And program evaluation is very important. So we presented with Angela Punnett at Concept last year how to develop advocacy curricula, but also how to evaluate them. And we found that most people that were there from both Canada and the United States that had similar programs had never evaluated them and didn't know how to evaluate their students in the areas of advocacy. And so we evaluated our program both in terms of the satisfaction and reactions of learners and supervisors, and also the learning of participants. Transformative learning, shifts in attitudes, and development of advocacy skills. So we, being Tina Martimoniakis and I, said this is going to be an effective program if transformative learning happens. And I'll show you how we did that. And so we looked at all the reflections, the surveys, observations, and we analyzed them for evidence of transformative learning. And then we categorized them according to phases of transformation, which were identified by this theorist, Meserow. And Tina and I are preparing a transcript for publication, and in the publication we have a student's reflection and go through how he goes through these 7 phases of transformation. First, in identifying a disorienting dilemma when a patient discloses abuse, examining their own feelings and assumptions, and then seeking new roles, new relationships with social workers, with residents, and planning electives in our child abuse program so that they can then learn how to work with these children and how to help them. So the student in our groups discussed this disorienting dilemma, but then also how they were going to move forward to learn more and help children in similar situations. So the first was this articulation of empathy for a population in a different socioeconomic status or privilege, and also that feeling of recognizing that we're privileged because we're physicians and we can help those that are less advantaged than we are. That identity as an advocate and the importance of being an advocate to being a physician, but also wanting to pursue a career as an advocate and as a child health advocate in particular. And finally, that feeling of empowerment, or as Paulo Freire called it, conscientization, where we recognize that we can do something to help those less advantaged than us. Paulo Freire worked with very poor people in the slums of Brazil who, through education, realized that they could help themselves and each other get out of the slums and do something better. And so here are some examples from the students. So they articulated a development of awareness of empathy and challenging their assumptions. So one student says, coming from privileged backgrounds, medical students like myself often underestimate the pervasive influence of socioeconomic conditions on needs such as obtaining treatment for medical conditions, having access to proper nutrition and care, all of which may have a more direct influence on disease than biology itself. Such realizations have inspired me to look at health from a more holistic social lens, with the primary goal of enhancing the social architecture for patients. And I would say that this is a common theme throughout reflections. And not all our students are privileged in a socioeconomic sense, but they recognize that they're privileged in having had higher education and in being able to help others. All of the students describe the importance of the role of physician as advocates and how they start to see themselves as advocates. So this one student said, the patient's parents are seeking help from community agencies, but they have struggled with accessing publicly funded care. Should he become diagnosed with a disorder, they will be unable to afford private services, and they will likely have difficulty navigating the maze of publicly funded community agencies. The barriers he and his family face highlight the obligations that we have to advocate for these marginalized patients. Before this summer experience, I had considered research to fall under the scholar CanMed's role, but the more I interact with patients and clinicians who face these barriers, the more I realize that research forms an integral portion of the health advocate role. Experience this disorienting dilemma, this discomfort, but with support, they displayed what Taylor describes as the courage needed to live with this discomfort so that one day they can help others and make a positive difference. So this student actually confronted a disorienting dilemma in her research data. So she says, my SPRESS project works with an extensive data set of health indicators of child health. These numbers make me uncomfortable. As I finished reading an article on the need for education to overcome social inequity, I was left a little frustrated. I had had enough of reading and talking about it all. I wanted to do something. I wanted others to do something more than talk and discuss and re-talk and rediscuss the same issues with different words. I want to be a doctor in a time when being socially aware and responsible is not something to be praised for, but something that's expected. To be this person, I know I will have to continue being uncomfortable. I have to continue seeking out experiences that make me face reality, be it good or bad. And the students write about how these feelings are reinforced through their readings and through the faculty that they worked with. They talk about their discussions with their supervisors in their reflections, or their discussions with the faculty that they shadowed in clinical practice. The students found the program both challenging and rewarding, particularly when we asked them to integrate their research experience with their own personal feelings and experiences. And the faculty similarly found the students to be engaged and reflective, contributing significantly to their projects and making connections between clinical and research experiences. And so I want to thank Denis for supporting the SPRUS program, Tina Martimaniakis for inviting me to work with her, the students in the evaluation of the program, and in particular the SPRUS students who have really challenged me to look at my practice as they observe me, and to look at my role as an advocate and whether I am doing enough as an advocate. And so here are some references if you want to read about some of the different studies that I mentioned, and I thank you for your attention.
Well, thank you, Susanna. It's now, my name is Tony Berezino, and I want to thank Denis and Doug and CAPHC for this opportunity, and to all of you in attendance today for both the invitation to speak to you, as well as the enthusiasm hopefully you have for this topic, which is clearly quite near and dear to my heart. Today we'll be discussing the barriers to and facilitators for the health of refugee and immigrant children in Canada, and with a focus on the Caring for Kids New to Canada web resource. I've spent the last 3 or 4 years acting as one of the 2 co-editors-in-chief, developing this resource and helping shepherd it to its online launch. And now it's my privilege and duty, frankly, to spread the gospel of CKNC and hopefully helping raise awareness of the healthcare challenges for newcomer children and youth in Canada. So this is a screenshot of the CKNC homepage. And if there's only one thing you remember after today, I ask that it be the link to this website, www.kidsnewtocanada.ca and www.enfantneocanadiens.ca. But specifically, we'll be speaking today about the barriers and risk factors. I'll briefly touch upon just 2 aspects. Obviously, first, the barriers and risk factors affecting the health and health outcomes of children newcomers to Canada. And then we'll very briefly discuss some of the ways we can facilitate better health outcomes and healthcare access for these patients, keeping in mind that 12 to 15 minutes certainly does not allow for a comprehensive review by any means. And at this point, I'd also like to give a special thanks to 2 colleagues of mine, Maureen Mayhew and Paul Calford, family physicians who sculpted this section for the CKNC web resource. And I also want to congratulate Paul, whose group have just recently received notice of an agreement for a permanent home in Scarborough for their new Canadian Centre for Refugee and Immigrant Healthcare. So kudos to them and congratulations. Now, let's briefly begin by looking at some of the barriers and risk factors that can affect the physical, mental, and socio-cultural health of children and youth new to Canada. So first, let's start by looking at some of the systemic barriers, particularly problems with eligibility and entitlement. Now, complexity is huge in this area. The various array of the federal, provincial, and territorial eligibility categories and rules can be mind-boggling. The wait times vary from province to province and between categories, and even the criteria for coverage seems to be ever shifting under the sand under the feet of the immigrants and refugees and care providers. We estimate that as many as 200,000 newcomers to Canada are either medically uninsured or underinsured. And is there an effect on health? We know that there is. And in fact, these individuals who are ineligible report higher levels of anxiety, of stress, and advanced illness when they finally do present for care. Knowledge of this status is very important, but it's not always easy to determine. The clients themselves have fear of the consequences of sharing their information. There's fear of authority figures, a feeling that they may risk their status in Canada. And in fact, it's often quite difficult for both the provider and the family alike to navigate the system, especially if you don't deal with these situations regularly. What about care provider related issues that are systemic? Well, certainly the lack of provider knowledge about the systemic hurdles is obvious, but also about the medical, the cultural, and the social context that can differentiate and complicate the care of newcomer children and youth to Canada. As well, there is limited access to care providers. Some self-restrict due to the workload required to care for this population, but there's also limitations inherent in the access due to language issues, payment concerns, and a general lack of discomfort with the issues that may arise in this group of patients. And frankly, it's just difficult to get a doctor in many regions, let alone to get someone who has an interest in immigrant refugee care. Now, there are also patient barriers and risk factors, and probably the biggest is culture and how culture can influence healthcare and health outcomes. Now, the iceberg analogy that I use here is not just to represent the, quote, what lies below the surface, end quote, component of culture, like communication or ethics or values or beliefs, etc. But it's also to remind me that the heft and the significance of that hidden material can lead to catastrophic consequences if it's not paid attention to. And I didn't get a picture of the Titanic here perfectly from the movie, but I felt this would do. Now, what aspects of culture can affect healthcare? So, for example, view of health and illness as seen through the lens of culture for families. Some cultures, for example, may value obesity as a sign of health and prosperity, not as a harbinger of potential illness. Patients also may have variable understanding of the cause of health and illness. The knowledge of infectious organisms or neoplasms can be limited or can be surrounded by mythology and beliefs that are shrouded in culture and backgrounds that can interfere and impact on care provision. Experiences and descriptions of symptoms such as pain, timelines, pain thresholds, willingness to admit pain that is not culturally accepted can interfere. And even an understanding and a compliance with treatment options. We know that these populations and these families are more engaged in alternative or complementary options, and there tends to be an innate distrust of medications or surgical interventions, which can obviously impact when you're trying to establish a treatment plan and a relationship. And even just the interaction with healthcare professionals. There's a mistrust of authority figures in general, and often healthcare professionals are lumped into that grouping, and it can make it difficult for communication. As well, there's stigmatization that happens, particularly for mental health issues, but physical as well. So things like HIV or depression are particularly good examples of this. There are other barriers as well, however. For example, the lack of familiarity with the healthcare system. Not knowing what can be accessed or worry about the consequences of doing so can lead to delayed or avoidance of care. There's also literacy and language gaps. We know that miscommunication can increase the risk of medical errors, of inappropriate treatments, and the frequency of emergency room visits. And cultural interpreters can facilitate both verbal and nonverbal communication and can mediate concepts and cultural practices that may not be familiar to the provider or to the patient themselves. There can be limited pre-arrival health care, everything from immunization status to chronic disease management that is different than the standard of care in North America, as well as even congenital anomalies in their management or lack of management. The migration journey is often an issue as well. The difference between arrival after having spent 2 to 3 years in a refugee camp versus being a family-sponsored immigrant can be quite different in terms of how the mental health and physical well-being of an individual upon arrival is viewed. And things like the precarious finances, the poverty, lack of social supports, all can have a huge impact on health, care access, and adjustment to the new environments. And once again, a mistrust of authority has to be considered because in many cultures or in many situations, individuals have experienced authority as equaling bad things happening in their lives. And for some newcomers, again, this extends to healthcare providers. So this is just to say that all the social determinants of health, frankly, are at play when it comes to patient barriers for this population and need to be considered. Now, let's take a moment to look at the ways of facilitating and supporting access to health care for kids new to Canada. So there's 5 things I think that institutions and clinics and individuals can do. It's not limited to 5 things, but certainly 5 that I think we can all sort of get our minds around. One, is inform. Inform yourself, inform your staff, inform your patients, keep information available and easily accessible, and if there's a particular population or cultural ethnic group that you work with, make sure that the pamphlets are language appropriate. Connect. The support services need to be part of common knowledge wherever you work. For your staff, the phone numbers, the emails, the websites need to be easily accessible and need to be provided to clients. The medical connection is very important, but this can be a big challenge as this population is not easy to care for and often comes with the additional challenges that not all family physicians, pediatricians, or care providers are prepared or willing to deal with. We need to be able to streamline the way that forms and payments and care is accessed. For your institution or your clinic, this can be a significant issue that needs to be addressed and dealt with, both the financial reality as well as for the flow and the logistics. You need to try to develop a better understanding of the criteria and the rules around coverage, a better knowledge of the IHF program and the access, the rules governing care provision, what is considered locally emergent or non-emergent, all of which can have major impact on a clientele's ability to access care in a timely fashion. I think we also need to be aware of the local services, and this requires education and some digging on the part of the care providers, and often it really develops over time as you get to know your community and the back phone lines of the various players. Being able to provide families and newcomers to Canada with options for primary care, for prevention, for free screening and dental, networking with social workers, settlement agencies, shelters, provision of financial aid, letters of support for housing, etc., can all make the adjustment and adaptation to life in Canada more streamlined and also improve their health outcomes. And finally, effective communication. Remember, culturally appropriate care starts and ends with effective communication. Make sure you understand how the patient understands what is happening. Recognize that families use complementary and alternative therapies. Take time to assess the patient's support system, their language skills, and their stage of adaptation to Canada. Find out whether or not a family or a patient would benefit from spoken versus visual messaging rather than printed health information. And at this point, I cannot overstate the importance of interpreter services and how it is incorporated into your day-to-day function, be it in a clinic setting, a hospital, or otherwise. And one of the other areas where you can find further information on how to reduce barriers to health care, access, and improvement in health in general. Obviously, I'm going to redirect you to the Kids New to Canada web resource. It's a great place to go. Here, for example, is an example, here's an example of some of the information that can be accessed online. This is a guide helping newcomers overcome barriers to health care. It can be downloaded and used to educate, to highlight, and to help advocate on behalf of your immigrant and refugee families. And I just want to say very briefly, although cultural competency itself is a lecture that we could spend an entire hour, but culturally competent care is important to the care of immigrant and refugee families, and it is something that can be learned and can be incorporated into your day-to-day existence. Also, use of interpreters, again, I will mention this only because of the importance, and the importance also of not using children as interpreters unless under totally emergent status. An accurate assessment of any newcomer child or youth requires complete communication without misunderstandings on either side, and it's far too heavy a burden to place on a child and may negatively impact family dynamics. And in fact, we at the CPS are working on a statement to that effect that should be coming out in the next several months. And here's a checklist, and again, another downloadable tool that can be printed off from the CKNC website and used as a practice tool or an educational opportunity or an advocacy piece. And we welcome you to check out the site to try to find these tools for your offices and hospitals alike. And in closing, healthcare providers are more likely to have positive interactions with their patients and provide better care if they can understand what distinguishes their patients' values and beliefs and practices from their own. this goes back to the basic principle that cultural competency can be a learned skill, and I encourage individuals who work in these with this population to work on their cultural competency. So, how can we make a difference? We need to be able to understand and help remove the barriers. We can work on facilitation and advocacy, but recognizing that it does require work and it does require some focus. And we certainly should be familiar and use the resources that will promote success, including interpreters and the local experts. And finally, one last shameless plug, the CKNC website, of course. And thank you very much.
Thank you, Dr. Berezino. I did intend to do a nice smooth transition from the previous speaker and forgot to unmute myself, so I appreciate you jumping smoothly in and starting your presentation. But I did want to mention, following that we did do a full webinar session with Dr. Berezino and one of his colleagues on our webinar program a number of months ago, and you can find that recording on our Knowledge Exchange Network. If you just search for Caring for Kids New to Canada, I'm sure you'll be able to find that and watch a full session with lots more information about their website and all of the resources that we have available. We also had a session with Dr. Karima Karmali from the Hospital for Sick Children on cultural competence. So Dr. Berezino mentioned the importance of cultural competence a number of times. So we also have a session on that on the Knowledge Exchange Network. So feel free to search for those and take up that information as well. And I just, before we move on around the lake to Hamilton, to McMaster University with Dr. Andrea Hunter, I did want to mention to everyone that you can ask questions. Please type them in as you think of them. We don't have any yet, but I just wanted to remind people, if you do have questions, please do type them in as you think of them, and any that we don't get to following the speaker, we'll be happy to entertain at the end of the discussion. So over to you, Dr. Hunter.
Great. Thanks, Doug. Good morning, everyone. It's my pleasure to be on this webinar today with some certainly esteemed colleagues. I've been given the topic of what should pediatricians be thinking and doing about advocacy for child health, perhaps a broader topic that I've been charged with by Denis and others, and perhaps a chance for some overview of some of the other topics you've heard about so far and those to come both today and next week. As in all good talks, I guess we start with disclosures and an outline. A few disclosures. Firstly, I'm not sure that I consider myself truly an advocate for child health or someone who does this full time, although I would consider it an integral part of my clinical and education practice. I do think that our frontline providers, our primary care, family physicians, nurse practitioners, and some pediatricians are certainly the frontline advocates for children, and that it's our role as pediatricians, both in the clinical realm as well as in education and leadership, to support these individuals and move the case forward. Secondly, I think that I'm just going to present a few examples of so many, given the short time frame of what we could be doing, and the sky's the limit really in this regard. I've separated things a little bit in our traditional trifecta here of clinical, education, and academic work and leadership. And to start off with some clinical examples of what pediatricians should be doing in advocating for child health, I wanted to start with a recent publication just a few months ago by Joe Radigan and his colleagues at Harvard around rethinking the social history. Thought it was really a very well written, articulate, passionate plea for going beyond the current topics that we've all been taught in medical school or residency or other health professional training around social histories of adults or children, and moving towards proposed new topics. And you'll notice the significant discrepancy here in the length of the list. And I'd also point your attention towards the access to and utilization of healthcare, that last bracket, looking at insurance status, at access in literacy and in medication, as well as barriers to making appointments that I think we're increasingly aware of, but perhaps as an institutional as well as individual level we can make further gains towards. There are a number of resources from a clinical perspective. This excellent resource by Julia Marinis, Leo Levin, Gary Block, and Lee Ford Jones, all in Toronto, as part of the Social Paediatrics Working Group of the Health Providers Against Poverty, published, I believe, in late 2013, looking at child poverty from a primary care provider's standpoint. And you'll notice that it outlines a number of quite well validated questions looking at advancing this mission. And I know that within primary care, and certainly all of us dealing with children on a frontline basis, we have innumerable questions to ask and things to screen for, but I think the individuals coming before me have certainly justified the need for us to expand that a little further than the typical history that we've been taking. And the idea of having trouble making ends meet has also been used in adult literature, and I like this graphic by Ritika Goel and Dan Raza in Toronto as well, placing that that question of do you have difficulties making ends meet just in the middle of a complex web of addressing poverty as one of the main social determinants of health, and some of the ways that they've mitigated that within a family practice context, including referrals and the idea from Gary Block's perspective of prescribing money, essentially through completion of taxes. As a few other sort of thought-provoking components to screening for social determinants of health within our clinical practice, I highlight one article that looked at randomization between electronic formats, so iPad surveys, versus in-person surveys in either English or Spanish at the family's request in a Southern American institution, a large urban pediatric emergency department. And interestingly, they actually found that there was a significant difference in the proportion of social needs items with higher endorsement in the computer-based group than the face-to-face group. And again, not to say that we shouldn't be taking histories in person and using translators and developing rapport with our families, but it does force us to be a little bit more creative, perhaps, or innovative around how we do accurate screening and appropriate screening in our busy clinical environments, and perhaps the value of each of those different types of interface. And again, as just one example of many, this was an interesting study done by a number of Scandinavian researchers looking at Arctic Canada and food security. And I mentioned food security, or I bring it up because I think it's quite a sensitive marker of essentially screening for low socioeconomic status, and something that feels a little bit more tangible, or a little bit more tangible both in terms of the resources we can access and interventions we can advocate for. And this group looked at using a U.S. Department of Agriculture household food security scale module, so an 18-item questionnaire, and narrowing it down to just one question that, as you can see there, had quite high sensitivity and specificity in detecting food security in this Nunavut and Inuit health surveys. So in the last 12 months, were there times when it was not possible to feed the children a healthy meal because there was not enough money? Obviously, there's many variations on the wording of this question, but again, the number of times that this is positive in my own clinical practice, and I believe in many of yours, is astounding in itself, and leads us towards some action. I can't help but mention that I'm biased by participating with Tony over the last number of years in Caring for Kids New to Canada web resource, and the clinical implications of caring for newcomers, particularly the need for excellent interpretation not done by children, and a welcoming environment for newcomers with cultural competence or cultural humility, and the importance of that to all providers, not just those who work in dedicated newcomer clinics, as some of us do. It highlights for me as well the component of health literacy. This is somewhat of a humor, to add a little humor perhaps this morning, but a graphic created by a colleague of mine with a graphic arts background of how to collect a stool sample for our enteric parasitic screening in refugees, but really also to highlight the need for many of our families to have non-written information around literacy levels, but also around language itself. And so in addition to those items of clinical importance that I've highlighted, I think the other key issue that the previous speakers have also raised is that of knowing your local resources. Getting, many of our residents get to know the community organizations, and they've found significantly increased success along with clinicians in hooking families up with appropriate resources and knowing limitations of those, and also the best connections and partnerships to be made. From an education or an academic perspective, I wanted to first highlight, as many of you have already, the health advocate role, or the revamping of this role that will be coming out shortly in the launch of CanMeds 2015, which is currently in Series 4 of discussion and review. I was privileged to be part of the expert working group for health advocate role, and I found amongst the many, many hours of discussion and fascinating discussion, there are a few components of change or revision in that health advocate role from 2005 that I think are worth highlighting. One is working with populations, and it's something we certainly encourage in our learners and do quite a bit of education around working with individuals and populations rather than working for someone. And both our role to understand needs, speak on others' behalf, but also support the mobilization of resources to affect change and to advocate for those resources, whether in our own practices or institutions. And I'm excited as we look through this competence by design and look through key and enabling competencies to see that advocacy requires action, has been highlighted in this new draft, and that an enabling competency that's highlighted is to participate in a process to improve health in the community or population they serve will be essentially a specialty requirement of every graduating resident. And after much discussion, I'm sure there will be quite a bit of innovation around how this is rolled out in various specialties, including pediatrics. I found it interesting that recently as well, physician leaders and pediatric leaders from the U.S. Have commented on the decreasing participation in community health activities by pediatricians, and you see the numbers there. And the two recommendations that came from some of their work, which I think holds true for sure in Canada, is the mechanisms needed to increase and improve training of our new advocates across the career life course, so both in medical school and residency and equivalent, but also beyond, as many of us have done much of our learning and advocacy beyond our residency, and also that the need for rationalizing protected and non-clinical time, or that a very valuable resource of spending some dedicated time doing advocacy work beyond our clinical practices. And Susanna highlighted it much more articulately than I can around her program for social pediatrics education within medical students. Here at McMaster just a year and a half ago, we started a similar concept based on some of the work at SickKids for our second-year pediatric residents to spend 4 weeks outside the hospital, quite intentionally, often learning from non-physician or non-clinician teachers around social pediatric issues. And all of our resources are free to access on the web, and we are in the process of evaluating this from a qualitative perspective around reflective learning as well, reflective practice. So as we close the section on education and academic perspectives, I also wanted to highlight the role that we play as pediatricians in setting research priorities. And I think one of Susanna's students highlighted this best in saying that research doesn't just fall under the CanMed scholar role, but can certainly have a role and should, I believe, under the health advocate role. So in our writing, in our scholarly work, in setting research questions and agendas with our institutions and our learners, I think we all have a role to play in considering the multidisciplinary and multifaceted aspects of social pediatrics and including that in our scholarly work. And finally, in leadership, both at administrative levels, physician leader levels, at advocate leader levels. I think a few comments, again, from my own perspective around welcoming nature of institutions. So is your institution, whether that be a clinic, a hospital, a community organization, is it welcoming to all socioeconomic status, the dispossessed, the disadvantaged, and the discarded, to newcomers, to Indigenous, to low socioeconomic status? Have you accommodated or thought through the process for those who are uninsured or underinsured, and where may you redirect them if it's impossible to care for them in your own institution or practice? Have you thought through the health literacy aspects and have either handouts in multiple languages or even better in a graphic format and in video format or others? Again, accommodating for the needs for interpretation and excellent translation services at all levels of contact. From both making appointments to informing families of appointments, not in a written long text as in many of my institutions, to triage to desk clerk level as well as physician and nurse contact. And then I think we all have a role to look at how we coordinate, how flexible we are, and the location of our appointments. Some of these are within our own hands and some of these are perhaps out of our hands, but considering the idea of outreach clinics that have flexible hours, coordinating appointments for busy working families who need to take time off work and pay for significant transportation costs to have their child seen by perhaps multiple specialists, and I believe IL will address this as well. Care navigators can mitigate some of this, and I think any screening that we do, both on a research or education or clinical level, needs to be put into action. And for that reason, I'd encourage institutions and leaders to look at the CPS status report, the latest one being in 2012. 2014 is on its way, looking at how Canadian public policy has been implemented in all the provinces and territories, and perhaps we need to look at this more at our own local levels, as well as institutions, to say, are we screening for things such as seatbelt use or booster seats, helmet use, sport activities, as well as a number of other components around our Canadian child health public policy issues. Finally, I believe the next speaker will speak more about pro bono law, but really as an example of the many partnerships our institutions and clinics can make to further the social needs and social advantages to our patients and families. And so, in closing, of a few ideas from my perspective around what leaders can do from institutions or otherwise around advocating for child health from a pediatric perspective. So what we can do, again, a bit more of a summary: becoming an expert in taking and teaching a social history and screening for those social determinants of health, knowing where to refer, striving for cultural humility and seeking out trained interpreters, being a role model in health advocacy to trainees, and advocating for advocacy within your own educational programs and institutions, and remembering it in research agendas and priority setting. And in leadership, are we welcoming to all families that we should be serving or that we should be reaching out to, and considering partnerships to advance that advocacy into action? And I welcome questions, thoughts, and perhaps at the end some discussion with my colleagues.
All right, thank you, Dr. Hunter. Once again, my chance to remind the audience to type your questions in as you think of them, and I think we'll continue on with our presenters and take those questions at the end. So now we're going to go back up the road, back up to Toronto with Leanne Chapman, who comes to us from the Pro Bono Law Office at the Hospital for Sick Children in Toronto. So over to you, Leanne.
Thank you. I think, first of all, just by way of introduction, I want to explain a bit what my role is within the hospital as the non-physician on this panel, and thank you again for inviting a lawyer to speak with you this morning. Part of my role here is to advocate for families individually, but also on a systemic basis, and that includes advocating for all issues that impact the family's health, which really covers the whole gamut of social determinant issues. One of the things I think that surprised me most, and perhaps shouldn't have when I first came here 6 years ago, was how great both the numbers and in impact status is on the health of children. Certainly at an inner city hospital in Toronto, but I think people find this across the country. When we saw Tony's numbers earlier about the number of newcomers to Canada, many of them with precarious status, we can see why that is. That has an enormous impact. The other thing I wanted to say, just coming from what the previous two speakers have been talking about, is the role of the physician as advocate. And that perhaps was one of the largest surprises when I first came here. I was unaware, having worked as a children's rights lawyer for years, and perhaps this speaks to the benefits of medical legal partnerships, which are springing up all over. I was unaware of the amount of work that physicians have been doing, not only within the hospital and not only within the traditional areas that we would expect them to advocate for children, but also, most recently, as we could see when the federal government changed interim federal health program, we could see that it was the physicians who took the lead role, both on the street and eventually in the court, and were enormously successful. So, in the past we thought of physicians as partners in providing the evidence, but not taking a lead so much in advocacy, and I'm happy to say that that's happening more and more. So thank you so much to all of you, and kudos. This morning I'm going to very briefly speak to the legal issues facing new arrivals to Canada. I'm concentrating on two overriding legal issues that all categories have in common. those related to their economic rights and obligations that are dependent upon their status, and second, to the legal process that they must go through in order to change precarious status, hopefully to permanent status. And in the interest of this audience, I'm going to focus really on the implications for health care. However, a general lack of knowledge about Canadian laws and systems can certainly affect all aspects of settlement, from negotiating school systems to dealing with family law, taxation, although in my practice I find that's also true of some Canadians who have been here for longer periods of time. That we've heard earlier, there are all sorts of other reasons why this is particularly impactful for newly arrived Canadians. I think the first legal difficulty that most of our families face on arrival is the complexity of the legal system. And what you can see here is a list, and some of these actually have subcategories that they break into. And as Tony stated earlier, many of our families do not know their status, and it's not a surprise when you see this, or the implications for their status. And that can make it very difficult for those who want to help deliver health care and other systems to newly arrived Canadians. As we can see here, and I'm going to briefly go through the main categories. Citizen, I think we all understand what that is. Permanent resident, this is someone who has the right to remain here. They can be deported for causes, generally just criminality or breaking conditions of their permanent residency. They have the right to all benefits that Canadians have, and this includes most refugees. People who are already identified as refugees will arrive as permanent residents. However, in some provinces, including Ontario, BC, and Quebec, when they do arrive, they have 3 months before they can access health care. During that time period, if they're not refugees, they won't have access to interfederal health program, and so they will join, despite having permanent residence, will join those who are uninsured. Temporary residents, there's multiple categories of temporary residents, from those on work visas to student visas. Generally, they must have some sort of health care coverage, but they have rights only to very limited benefits, including EI, and they may not have any coverage for drugs. Visitors, again, we know who these people are. They come in, they plan on staying for a short period of time. Sometimes things intervene and they end up staying for longer. And sometimes they're here for a short term, and unexpectedly they fall into ill health, or their children fall into ill health, and they are joining the ranks of the uninsured. The non-status, many of them have been here for years. They have no legal right to be here. Most of them originally came in as visitors, or they applied for refugee status and were denied refugee status, and they find themselves without any kind of benefits whatsoever. The same with the illegals, and this is a small category. I know some people find the term offensive, but it is a legal category. These are people who have already received their deportation notice, and they are the people who are the most concerned about being discovered. They've gone underground, and they can be immediately detained and deported. These are some of the most vulnerable people. They have no access to any health or social benefits whatsoever, and that's not only government benefits, but it's also virtually every charity that we deal with will not include this category. The only benefit they have in most provinces is that they can attend school without fees. Although in Ontario and I think some other provinces, we do have some primary health care centers, or as we just heard, we have some ones that are non-government set up clinics for the uninsured. Just a quick overview of what a refugee is, and these are people who arrive both as refugees and people who will come here and claim that they are either refugees, which is part of being part of a larger group, or people who individually face torture, risk to life, cruel and unusual treatment, or cruel and unusual punishment. Cruel and unusual treatment can include health care, a complete lack of health care in the home country. Just to give you an idea of the numbers of people who come to Canada as refugees and where they have traditionally come from, unfortunately the most up-to-date statistics that I could find are 2012, but the countries have generally not changed, nor have the numbers changed much over the last few years. And when you consider the millions of people who are sitting in refugee camps already identified as refugees awaiting resettlement, you can see that the numbers are quite small. Refugee claimants, and these are people who usually identify themselves as refugees. Refugees are permanent residents when they come, so you might never know that they are actually refugees. Refugee claimants arrive here, they've not been identified previously. You can see by the numbers they're as large or even larger in many years than the number of refugees that Canada takes from other countries. These people are going to face an incredibly lengthy process. In the past, the average claim has taken up to 4.5 years. During that time, they do have interim federal health coverage. They do have access in most provinces to social services, which means that, and social assistance, which means they will have some drug access. But the numbers of successful claims are remarkably low, considering the number of people that come in and the number of refugees we take. It's roughly 50% or somewhat below 50%. So a lot of those people who come in as refugee claimants are going to find themselves non-status within a few years. And of course, for them, the difficulty is after having spent 4.5 years perhaps in Canada, they've resettled. They've got jobs, they've got friends, some of them have family here. Many of them will have had their children born here. Their children may be Canadian citizens. They feel very much a part of the country. And recent changes mean that only for those who who have children, they're not going to be able to go on to make any other claim. They're going to be removed from the country despite the number of years it's taken. Now, the government said that one of the reasons that they made changes in the last couple of years to the refugee law process was the extreme numbers who are backlogged in the process, and also the fact that it was taking 4 to 5 years in most cases. But you can see it's not exactly what we would call streamlined. It's an incredibly complicated, complex process that the families are going through. In many provinces, several of the provinces, they will have a legal aid certificate available to them, so they will have legal help through the process. In some provinces, they don't. But with or without a legal aid claim, it's an incredibly complex, long process. And it's not a surprise that many of them don't know where they are in the process. And it was mentioned earlier, in order to still access interim federal health care, they have to renew every year. And it's a very, if you look at the documentation they're given, it's not clear to them. And one of the things that the hospitals can certainly do is to try to help educate people as to their obligations under interim federal health program, and that's certainly one of the things we're working on. Humanitarian and compassionate claims are the only claims that are really open to many people who want to stay within the country and make a claim. As you know, most people make a claim for status outside of the country. For those people, it has to be exceptional. They have to show that there are factors that sort of outweigh the usual prohibition about claiming status from within Canada. And they look at things like how settled they are in Canada. And for many of our families who don't speak one of our official languages, that's a huge barrier right away. Ties in Canada. Happily for most of our populations, one of the things that they can take into account is the best interest of the child. Awaiting this process is approximately 18 to 24 months. Unless you are lucky enough to still be in a province that will afford you social assistance help after having a failed refugee claim, you're not entitled to any benefits during that period. No health benefits, no other social assistance benefits until you have a notification from the federal government that you have made the first step towards that they have accepted you provisionally to be a permanent resident. Until then, you are really living without any benefits whatsoever. The other way is sponsoring a family member from within the country. You can do that for spouses and children. If it's done within the country, again, it's a lengthy process, approximately 2 years. Up until a year ago, the spouses couldn't work while awaiting that decision. So this government had stopped them from getting work permits, which meant the families were very precarious, and even more so because in order to sponsor the spouse, you couldn't be on social assistance. So, you had to have the one spouse working to try to bring the other spouse in. They couldn't collect anything that was in the form of social assistance, and that has been interpreted to include even such things as subsidized daycare. So while they're waiting for the sponsorship, it's a very precarious financial position to be in, and legally beyond that, they are obligated to be financially responsible for the spouse for 3 years, for children for 10 years, and for parents or grandparents for 20 years. And that means none of the parties during that time can collect any form of social assistance. So that's a huge undertaking, and it puts a lot of people at a huge financial risk. I'm not going to go through these one by one because it is far too complicated, but as we know, Doctors for Refugee Healthcare did bring a constitutional challenge last year to the changes of IFHP, which would have divided categories between designated countries of origin and non-designated countries, and some of those people would have had virtually no health care coverage, only public health and safety coverage. It was struck down, and reinstated changes mean that for children, we're virtually back in the same place where we used to be, where they have both basic and supplemental coverage and prescription drug coverage. But for most other family members, as you will see, so even within the family, other family members will not have the same health care coverage. So again, it adds to the complexity and the precariousness of the status for people. In quick summary, I would say, first of all, that the numbers, as we can see, are significant for people who have either precarious or no status. The process is lengthy and complex. There are no access to benefits during many of the processes except for refugee claims. Compliance issues that result from no ability to pay for drugs can trigger welfare reporting, and this we find quite often with families, that a drug is prescribed for them, that the families cannot comply. They may or may not have express their concerns to someone within the hospital or to their physician that they can't, and we find out that they're not complying, there's no treatment, plans that are being followed, the drugs aren't being bought. We can sometimes find short-term solutions for that, but in the end, noncompliance can sometimes trigger welfare reporting, and in some cases, apprehension. So it triggers all sorts of other legal issues, unfortunately. Some of these families will not be able to be removed to their home countries because of safety issues, but they will still have no status, so they'll be in kind of a limbo for years. The sponsorship undertakings preclude some social safety nets for up to 20 years. And with all of this, even though we have best interest of the child, we also have a category of medical inadmissibility for families. So if the health care costs are very high compared to the average Canadian, then they can be denied status on that basis. However, we do have, happily, the obligation to take into account the best interests of the child. I'm going to end there. I think other people have talked about some of the things that physicians can do and that we can do as a group. One of the most important things I think that we can do is work together and advocate together for change, both within our organizations and also at the legislative level. Thank you.
All right, thank you, Leanne. Fantastic presentation. And if anyone wants more information about the PBLO program, they do have their website. But we did almost 2 years ago do a presentation on the CAPHC Presents series where we brought the program at Sick Kids along with a similar program at the Children's Hospital at the London Health Sciences Centre. And we had a couple of presenters from the Sick Kids program. Julie Keegan and Hannah Lee presented much more. They had much more time to present on their program. So if you want more details beyond just the focus on the refugee piece there, then by all means go to the Knowledge Exchange Network. You can always catch up on that presentation from a couple of years ago if you want to learn some more of the details of the benefits of that program. So now we're going to stay in Toronto this time, and we're going to hear from Dr. Ayel Cohen to tell us a bit about the medically complex children. Over to you, Dr. Cohen.
Thanks, Doug. Can everyone hear me? Can you? I presume yes.
Yes, we can.
Okay. So I've been asked to talk about the socioeconomic impact of a child with medical complexity, obviously from the perspective of the child and their family. and it's a pleasure being here and speaking with everybody. So I'm going to talk very briefly about three things. A little bit about the epidemiology of a growing population of children I'm going to call children with medical complexity, and explore some details about the socioeconomic challenges faced by their families, and outline some high-level approaches to meeting their service needs and gaps in service delivery. So anybody who works in the children's hospital sector can probably attest to this, and probably people in the community as well. We're seeing way more children surviving serious, complex childhood diseases than ever before. It's been one of the grand successes of the pediatric enterprise. Due to medical, surgical, other technological advances, we're seeing burgeoning populations of children who are highly dependent often on medical services, technology assistance, and other forms of support to help prolong their lives, which in many ways is a good thing. And this population that's been emerging has sometimes been called children with medical complexity. It's a term that's been debated at times. Perhaps a more appropriate term is children with health-related complexity, to also include those with serious behavioral and mental health issues. But the definition of the population is, one approach that's been proposed has been children who have substantially increased healthcare or health-related needs that often have substantial burdens on the family due to characteristic severe chronic condition that is associated with functional limitations and high resource use, so need for many different services from many different providers over time. And I alluded to this before, but there is no doubt that this population has been increasing in prevalence. This is one of many studies that have looked at this question, and it's chronic disease in general in childhood has been increasing in prevalence. So if you lump in conditions like learning disability, asthma, those sorts of conditions have also been increasing in prevalence. But in particular, and this figure shows it quite nicely, the greatest increase in growth has been in children with what we call progressive conditions. And the impact of this population is substantial. Again, even though there's been growth in the group, overall the numbers are still relatively small. They account for about 2/3 of 1% of the entire child population. But from a resource consumption perspective, about 1/3 of all child healthcare resources are attributed to this group of children. And despite this growth, and this has been well described in the adult healthcare sector, we still sometimes struggle with the architecture of our healthcare system, which is which was designed to be primarily focused on acute care and less on chronic care. And if you look at resource allocation and its relativity to disease trajectories, this is a figure I actually borrowed from a colleague of mine in the adult health sector. What we find, and anecdotally I think any clinicians on this who are involved in this call can probably attest to, is while we sometimes, not always, but sometimes have enough resources to care for this population when they're hospitalized, the substantial and growing amount of time that they spend in the community is often very, very difficult to support them. They still have quite active issues, but often we struggle with our ability to provide enough support for these children and their families. And as a consequence of that, this is thought to be an at-risk population. They're at risk of very fragmented care with poor care coordination. They're at risk of frequent and often, I would say, unnecessarily prolonged hospitalization and unsafe care. There's lots of data to suggest that the impact on their parents, who are tasked often with almost all of their care, particularly in the community, is enormous, with increasing rates of mental health and physical health problems, stress and burnout. and also financial difficulties because of the costs that are borne out of pocket often by families. One study from the U.S. Found that over half of families of children with medical complexity had at least one parent leave their work in order to care for their child. And although that hasn't been replicated in Canada, it wouldn't surprise me if that's true in Canada as well. I'm going to present a little bit of data, not a lot. This is from Ontario. I apologize I don't have data from the rest of Canada, but this is where this is work I was involved with at the Institute for Clinical Evaluative Sciences. So this is population level data, and I'm just going to walk you through some of this, and this really shows the effect on family socioeconomic status. So on the left of this figure, what you see is this is a birth cohort of infants born, those who are healthy and those who are born with a diagnosis of a complex chronic condition, so something like congenital heart disease or cerebral palsy, to give two examples. This looks at what happens to them over time from birth, that's the blue bars, to age 5, that's the red bars. So the first group on the left are those who are born healthy, and looking at those who are in what's called quartile 1, which is the lowest income, quintile 1, which is the lowest income quintile. So this is a proxy for poverty. And what you see here is that right from birth, children with complex chronic conditions are more likely to be born to poor families than children who are, or infants rather, who are healthy. And this is because we know that the social and socioeconomic determinants of health are risk factors for having chronic diseases to begin with, things like antenatal health, environmental exposures, etc. And by the time these children are 5 years of age, in both groups, both those who are healthy and those who have complex chronic conditions, you see an attenuation of this poverty. And the reason for this is as families are establishing themselves, they tend to, some families tend to move out of poverty. This is why we see such high rates of poverty often in early childhood. But if parents establish themselves in their vocations, often that is attenuated, and that happens obviously in both groups. But what you see here is that the attenuation is much more dramatic in those who are healthy compared with those who have complex chronic conditions. So by the time these kids are 5 years of age, when you look at the healthy cohort, you see a very similar rates of families who are in the lowest income quintile and the highest income quintile, so poor versus rich. Whereas those who have complex chronic conditions, you're starting to see a widening of disparities between within this population. So it's still very much more in poverty than those who are in the highest income quintile. An interesting perspective of looking at this issue is from the perspective of unmet need. So unmet need is, there's some nice longitudinal surveys in the United States that have looked at the relationship between how much families report unmet healthcare needs and in their relationship to a whole bunch of socio-demographic and socioeconomic variables. So it's well known that with chronic disease, socioeconomic variables are strong predictors of unmet need. To give an example, a child with asthma who's unable to afford their medication is not going to be able to have all their healthcare needs met. But what this recent study that came out of the U.S. has shown is that when you start getting into the upper strata of complexity, these really uber complex patients, the complexity in and of itself is a strong predictor of unmet need. Whereas with children with other more, I'm going to use the word milder, but that's probably not the appropriate term, chronic diseases, it's really socioeconomic variables that drive unmet need. Once you get to child with medical complexity, it's a complexity, the medical complexity in and of itself is a strong predictor of unmet need. And it's not necessarily even associated at all with traditional socioeconomic variables that are known to be associated with disparities. And this has probably been most, the most extreme example of this, I think Leanne alluded to this a little bit, is actually known documented cases of families who've had to give up their children to child protection services and authorities, basically giving their children up to the state because they're unable to financially afford or be able to have enough services to provide care for their children at home and in the community. And there was an ombudsman's report in Ontario a few years ago that alluded to this specifically with the population of children with severe neurodevelopmental disabilities, where I forgot the exact number, but there was a substantial number of children who were reported in Ontario at the time whose families actually gave up their children to Children's Aid Society, not for any reason other than their inability to provide their children the necessary care. So moving from that to things that work well. So we know that there are ways of delivering better services for these children and their families, and that usually is within coordinated service delivery models. And coordinated service delivery goes beyond healthcare services and into other sectors as well, including school services, child and youth services, and other sectors as well. Unfortunately, our systems of care, both within and external to health, are often much more balkanized than that. And what we end up finding is families often describe their services as looking a little bit more like this diagram, this vortex of relationships between different providers and different organizations and different service agencies, delivering what is clearly a disorganized way of providing services to the child and their family. And what we can do from an advocacy perspective, I think, are twofold. So on one side is the whole notion of providing better care coordination, and there's been a growth in this notion of complex care management. Most of it funded primarily in the adult sector. It's been a little more challenging to do this in the child health sector, but there are different ways this has been accomplished. One is by assigning care navigators. I think Andrea spoke a little bit about this earlier, to families to help them navigate through the system, even within a single organization, or ideally across organizations. A second is a notion of care planning. So much of our documentation and our interrelationship with patients and families is episodic, but when a family and a child is interacting with multiple different providers, recurrently over time, what they really need is summative ways of describing what the child's underlying health and other needs are, and care plans is one way of doing that. And the third way is actually the development of what are called structured complex care teams, and virtually every large children's hospital in North America now has, to some degree or another, a complex care team nested within the hospital, and this is another kind of evolving model of how to coordinate care better for these children. From a policy level, there are things that are going on to develop strategies to better coordinated service delivery. So when I talk about complex care management, it's much of it is very clinical and in a way medical around delivery, coordinating subspecialty opinions and visits, those sorts of things. But when you really speak to families, many of their needs are really much more along the lines of what is the service planning within the community sector. And there's some work around that. For instance, in Ontario, there's an interministerial strategy that is currently being promoted called the Ontario Special Needs Strategy to try to really focus on seamless service delivery within the community sector. And that crosses into mental health, that crosses into services delivered by rehabilitation organizations and services delivered by schools as well. So lots of different things going on from an advocacy perspective in order to try to avert some of the difficulties that we are encountering in delivering more coordinated and family-centered care to these children and families. So I think I'll stop there because I was asked only to talk for 15 minutes, and I'll pass on to Doug.
All right, thank you, Doug.
Can I take over and direct some of the questions while we wait for others to chime in?
Absolutely, go right ahead.
So I was interested by a couple of C words that came up. Susanna talked about conscientization, and Tony talked about culturation. Do you think we're teaching our medical students enough about social determinants of health? They seem to think that they're getting about enough. and yet when it comes to putting our feet to the fire as practicing physicians, we don't seem to do it well enough. Any comments, Susanna or Tony?
Yes, Dennis. So the students definitely think that they're getting enough. They often talk about their Determinants of Community Health course. They make links to that course when they're in the Express program. And some students will even say, a lot of what we learned in the Express program we already knew. But it's really that feeling of empowerment or conscientization that you need, because at times I'm sure we also feel like, we're
You've gone off
do anything to solve them. And so, we need that feeling of empowerment that we can actually do something with our knowledge of the social determinants of health, but with the resources that we have.
Tony, your comment?
Dennis, this is Tony. I would echo that. I mean, I think the how much education you receive and then how you actually put it into practice is always the challenge, right? It's the 10,000-hour philosophy. So understanding the theory is great, and it's certainly come a long way from when I was a resident, but actually then translating that into day-to-day function in your practice, in your teaching, in your research, that's where we're going to make the change, and that may be a generation before that happens.
And it's by looking at each other, so what AL is doing with complex care, that we sort of say, okay, if they could do it, then I could do it. With the resources that we have, we can do something.
Andrea, I have a question for you.
Sure.
It seems to me that what you said is that you thought that the people who should be advocating for child health and well-being are the people on the front lines, yet the family practitioners have so many different, they're balkanized in so many different areas, special needs adults, the aging population, etc., that it's very difficult for them to look at this relatively healthy population called children, that they often don't spill over into the public health arena. So maybe it's really our domain to lead that, not to do it all, but to lead it.
I would agree with you entirely, Dennis. I think what I meant was that I think we need to applaud that the primary care providers, so family physicians and nurse practitioners, and to some extent primary care pediatricians are doing an excellent job already at advocating, I believe, on an individual basis, and probably our leads in screening and in early literacy interventions and those sorts of things, and that it's our job as pediatricians and educators and researchers and leaders to sort of further support them in that as the front line, but look a bit more broadly, as you very articulately introduced, to the public health levels and to the secondary and tertiary centers and how that intersects with social determinants of health.
Leanne?
Yes.
Is the fact that you have the word lawyer attached to you a deterrent to bringing the disadvantaged families actually into the system because they're scared of revelation, of exposure?
I mean, I think initially that can be so. Now, the way the programs work is that it's by referral only. So they're already being referred by a clinician that they trust. And, the first thing that I can tell them is that, in fact, I am the only person that you can completely trust as far as confidentiality rules go. I'm held to a higher standard than anyone else. So that, that's explained right away. But it's very important that I'm embedded in the hospital and that it's seen as part of the clinical team where they've already built up trust. And it makes a huge difference. And to get back to what you're speaking about, the role of the advocate, I've been seeing, since I've been here, more and more clinicians not only, as they've always done, advocate on an individual basis, but more and more interest in systemic advocacy. So not only on the IFHP case, but, for example, one of the social workers who works with E.L. Cohn came to the legislature to make submissions on a bill to amend child welfare law to allow access to the same sort of special needs agreements, et cetera, that are available to the under 16, to the over 16, to the 18. So we're actually...
I'm just going to try within the next 30 seconds to get Ayel's question in, if you don't mind.
Sorry.
Ayel, are you there? It seems like we can't afford to have the integrated system, and we can't not afford the integrated system, because if we keep what we've got, it costs us too much money in acute hospitalizations, and yet to transfer this into a more community-based system that you've done is hellishly expensive, it seems to be. How are we going to do this?
It's happening anyways, just the money is happening. It is only going through the adult sector. So I think our advocacy is to convince the government that the stuff they're doing with Health Links, the stuff they're doing with a lot of the family health teams, developing interdisciplinary teams, there's a role for child health organizations to also be a part of that. And the most success we've had has been in, I think, when we've been able to coattail to adult initiatives.
So just before it turns 12:31, I want to say thank you to Doug Maynard again. Thank you to CAPHC for hosting us. Remind everybody that this has come about from the Pediatric Chairs of Canada, and I think today's session was very thought-provoking. And for all those who were listening out there, I hope you got what you intended to get out of it. Thank you very much. Over to you, Doug.
Thank you, Dr. Daneman, and thank you, as you said, to the whole panel. It really was a fantastic presentation. We did pretty much use up the whole time, so if anyone did have a question that we didn't get a chance to get to, by all means, as I mentioned at the beginning, we do post this information all on our CAPHC's Knowledge Exchange Network. There is an opportunity for comments at the bottom, so you can always post your comments there, and can, as I said, continue this discussion that we've started here once again, and it really was a great discussion. We do our webinars every Wednesday at 11 a.m. Eastern Time, and it's always great if you can watch live, as you do have the opportunity to post it, to hear the discussion and contribute those comments. But if you can't watch live, as I mentioned, we do record these and post them on the CAN. Coming up next week, we do have part 2 of this series, so we'll be joined once again by Dr. Daneman, as well as the current chair of the Pediatric Chairs of Canada, Dr. Jim Kellner from Alberta Children's Hospital, and along with a new panel to talk about a number of other issues related to social pediatrics. So we'll be welcoming Dr. Lisa Robinson, Dr. Lindy Sampson, Dr. Sloan Freeman, and Dr. Roxanne Goldade to join us to talk about a number of other issues to continue, again, this topic of social pediatrics. Following them, after a short 2-week break, we'll be coming back with Dr. Keiko Shikako-Thomas and Dr. Annette Majnemer to talk about LeisureNet and some research that they've done around policies that support leisure and fitness activities for children with disabilities. So be sure to join us following our short 2-week break in a couple weeks' time. So thanks again for joining us. Thanks again to the panel, and hopefully we'll see you back here next week. Bye, everyone.